Hey guys, welcome to the UNC Neurosurgery Med Student Primer Series. I'm Marty Piazza. Today we're going to be talking about upper cervical spine injuries. It's part 3 of our set here, and we're going to specifically be reviewing C2 fractures. So the DENS fractures are the things you'll hear about probably the most. Note that the term DENS and odontoid process, like I mentioned in the previous lectures, are often used interchangeably when discussing this projection from the body of C2. All right, so there are 3 types of DENS fractures, and this is something that you should definitely know because you might get asked about it. The first one, type 1, there's a fracture of the tip of the odontoid process. In isolation, this can be managed with an external immobilization device. However, there are some ligamentous attachments here, particularly the apical ligament, that can put the patient at risk for an unstable injury. So these patients should definitely be evaluated carefully with X-ray or MRI to rule out a concomitant AOD, and you can hear more information about atlanto-occipital dislocation in part 1 of this series. Type 2 fractures are fractures at the base of the dens. This is the most common and is quite common in the elderly, as the vascular supply at the base of the dens is poor, and subsequently the bone quality is poor here as well. There are multiple considerations for treatment options of this, and we're going to discuss that in the next slide. And then type 3 fractures are fractures that extend within the body itself. These are generally stable and can be managed with either a halo or a collar. Typically, we will collar these patients here, but you can also halo them if you're concerned about compliance of the collar. There's a 97% fusion rate with halo and only a 50 to 70% fusion rate with collar. And you have to follow both of them with serial x-rays to make sure it's healing appropriately. All right, so as I kind of alluded to before, management of type 2 odontoid fractures can be quite complicated, and the treatment depends on the age of the patient and the fracture orientation, as well as the ligamentous integrity. Typically for adults, the non-union rate with external immobilization for these is at least greater than 40%, and sometimes can reach up to 86% of non-union if there is greater than 5 millimeters of displacement. Doesn't seem like external immobilization is a good option for this type of fracture in adults. Children, however, especially those less than 7 years old, heal quite well with external immobilization of this fracture. That being said, children don't get this fracture very often. So you're most likely, like I said before, you're going to see this fracture in kind of elderly adults. Surgical options for this fracture include odontoid screw and a C1 to 2 fusion. Now, an odontoid screw seems like it'd be quick, not very morbid, but you need to have a great setup for it. The first thing you need to know is if the injury is amenable to it. And in order to know this, you need to know if the transverse ligament is intact, or the bone fragment is going to be pushed into the spinal cord when you try to get purchased with the screw, and that's bad. The transverse ligament is going to provide that back pressure for the screw placement. You also need quite a steep angle to get the right trajectory for the screw. So a patient that's barrel chested or large for whatever reason, an odontoid screw is not going to be a good option for those patients. It's generally reserved for thin patients. Posterior fusion can be much more reliable and can treat multiple types of DENS fractures, and you don't have to have all these prerequisites as you do for an odontoid screw. All right, so let's talk about Hamans fractures. So Hamans fractures are bilateral C2 pars fractures, or traumatic spondylolisthesis of the axis is another way to describe it. There are several types. Type 1 is non-displaced and can usually be treated with a collar. Type 2, it's a vertical fracture through the pars, and there's disruption of the C2 to 3 disc. If there's less than 5 millimeters of subluxation and the angle is less than 10 degrees, you can treat with gentle traction followed by a halo. Type 2A is an oblique fracture through the pars. There's little subluxation, but there's a larger angulation, at least 15 degrees. These patients are going to need surgery, and it's typically in the form of a C1 to 3 fusion, especially if the C2-3 disc is injured. I would caution doing traction in these patients because that can make the deformity worse. So surgery is really the only option here. Type 3 fractures are vertical fractures through the pars with bilateral C2 to 3 facet disruption. The facets are locked, but you cannot use traction here because it can be quite dangerous. Therefore, you need to do an open reduction and fixation with a halo. All right, you made it through our upper cervical spine injury series. Here are our references, and please follow us on Twitter for more information on future educational content we'll be releasing. See you next time.